my sister. I'm so happy that you're on the call. Good to see you.
Hi, Ron.
Hi. Are little kids more prone to this strain? No. I'm glad that you brought up the strain question. That seems to be really all over the media. So to your question with respect to kids, I don't think there's data on that, but the answer is almost certainly no. Kids seem to tolerate this problem much better than adults anyway. But it's with respect specifically to the new strain. let's just talk about that for a sec. There's only one. This is kind of pedantic, so forgive me. There's only one strain of SARS-CoV-2 virus. Like, people are throwing around the word strain. It's important to remember that this is just the same. It's one virus. It's not going to, if it mutates to where it becomes another virus or another strain, then it's not SARS-CoV-2 anymore. There are variants. There are multiple variants, and this is an expected phenomenon with viruses. And so what happens is they mutate. And with RNA viruses specifically, they don't have like a real good repair function like DNA viruses do. They have a higher fidelity when they replicate. The RNA viruses do not, and RNA viruses mutate continuously. The influenza virus is sort of the poster child for the mutating RNA virus, which is why you have to get a different flu vaccine every single year, because it changes that much. And some years it shifts like entire segments of its genome, and making it a virus that you need a totally brand new vaccine for. And that happened in like 2009. Those are actually called pandemic flu variants. There are many variants that have been identified recently, and they have been all over the news. And I know you've heard of them: the UK variant, the South Africa variant. You're hearing words on the news such as vaccine escape and loss of immunogenicity. And I just want to be super clear. This is really interesting stuff. But let me just start by saying the science hasn't been done to fully understand the implications of these variants. They're doing it, and it's starting to come out day by day, but they really need to do these experiments, to see if the protein structure of the new variant is significantly different enough to where it might evade your immune system or evade a vaccine. Or the other one that everyone's talking about is that they are quote unquote more infectious. There's definitely a plausible argument that a variant of an RNA virus will become more infectious, and they do that by binding with higher affinity to the target protein on the cell, et cetera, et cetera. They just more efficiently can infect their host or get into your cells. And that's if you're a virus, like if you pretend you're a virus, what you want to do is you want to replicate. You want to spread as much as you can so that you can replicate as much as you can. And so from an evolutionary perspective, it is advantageous to become more infective and less lethal. And because you don't want to kill your host too fast. That's why you're never going to see like a worldwide Ebola outbreak that's going to sweep across the globe, because it moves too fast and it's too lethal. So you want to become more infectious, more efficient at infection, but less lethal. And it does seem that the binding characteristics of some of these variants, like they've done a bunch of studies on this UK virus or UK variant, and a little bit on the South Africa variant is coming out like literally like as we speak. And there is some suggestion that it has like a higher binding affinity to the receptor domain, like the spike protein, which I'm sure you may have heard the word spike protein in the news. But the reality is there is really little evidence or no evidence or reason at this point to believe or to worry about things like immune evasion or vaccine escape, wherein the virus is no longer like susceptible to your immune response or susceptible to the vaccine, the antibodies that are produced by the vaccine. Because when your body responds to an infection, it makes a whole ton of different antibodies, and they all have different sort of quote unquote neutralizing effects. And a lot of that has to do with the areas on the target protein that they bind to. But like say in the case of SARS-CoV-2, or the neutralizing protein is called the spike protein. And everyone's talking about how the vaccine produces these antibodies to the spike protein, but now the spike protein is mutating, and so therefore the vaccine
work. Remember, when you get a, can you guys still hear me? Something just happened with my computer. Okay. When you get a vaccine, when you get a vaccine or get infected, your body makes a whole bunch of proteins, and there's a bunch of different little spots or antibodies, and there's a whole bunch of different little spots on the protein that different antibodies bind to. So a couple of mutations in the protein itself, and the virus is very unlikely to create a situation that your immune response or the vaccine response is not going to be effective. That's a long way of saying it doesn't change a thing. If the new variant is more infectious, what do? You wear masks and you social distance and you get vaccinated. If it's the vaccines that we have available, these mRNA vaccines specifically, they're very easy to tweak. If the virus were to gain a function that made it evade the vaccine, it's very easy to get a booster that's slightly different, that's going to make different antibodies that are more target that protein. It's really not something that most people are very concerned about at this time, particularly with respect to little kids. Sorry, I kind of went on, I digressed a bit there just because there's a lot going on in the news with respect to these variants, and a lot of it sounds pretty like doomsday. And I just don't think that any of that is justifiable from the science that's available. It just makes it more, the bottom line is this: you got to get vaccinated, because the best way for the virus to mutate is to have a whole bunch of virus circulating all out in the community. That just gives it this opportunity to mutate. And some of the most impressive and I think interesting biology that's been coming out with the COVID virus is some of these patients, like these immunocompromised patients, like cancer patients. We have a lot of these at UCSF. They will be actively replicating COVID virus in one host, in one human, for months. And there have been there's been some theories, and I want to emphasize theories, that some of these variants occur in these settings when the virus is replicating in one host for months and months and weeks at a time, because it gives it more opportunity to obtain these mutations that might be advantageous biologically. So the faster we can vaccinate everybody, the less and the more careful we can be with masks and distance for the time being, the less virus circulating in the community, the less we're going to see these variants. The last thing I would say about the variants is they're popping up at the news right now, it seems like left and right. And I think part of that is because we're getting a little bit better at genome sequencing. The US has been terrible at sequencing these viruses. There's only a couple of labs and people that are really sequencing a lot. We're not doing a lot of sequencing in the States in general. I think more now. But there are other countries that have done well at this, like the UK. And if you look at these phylogenetic maps of the virus, you can see that there's been new variants popping up, throughout the whole pandemic, including the one, remember, in, I think, April or March in New York, they're oh, new variant, it's more dangerous. But I think we're doing a lot more sequencing now, and I think that's why we're finding all these variants, and that's why the news is picking up on this. But if any of you are worried about these variant things, don't sweat it. Just wear a mask and stay away from each other for a little while, and get vaccinated. I mean, I hope we'll get back to the vaccine and talk about that, but that's the way out of this problem, is vaccinating everybody. All right, that's variants. Anything else on the variants that anybody wants to jump out and say?
I have one more question, and I have to pop off. Do you think that there's a difference between the Pfizer and the whatever vaccination? Is one better than the other?
Pfizer Moderna?
Yes, thank you. It's a kind of loaded question, but I'm just curious because I've seen things on the news, of course, where there's reactions happening, some of which are mostly women. And of course, it puts stuff in my brain, and I'm just curious if you have any insight into that.
Yeah, so two questions. One, the first one, is there any difference between Pfizer and Moderna? And the answer is no. They, I think of them interchangeably. From a biological standpoint, or a molecular standpoint, they are basically identical. They both have the RNA sequence for the protein, the spike protein, inside this nanoparticle, and the two different companies made their own nanoparticle, and it's proprietary, and they won't tell anybody what the nanoparticle is made of, but it's basically just like this lipid thing. So they are essentially identical as far as their efficacy and their do they work, are they safe? I consider them identical. The second question, the second part of the question is a little bit tougher, and I'm glad that you brought it up because it has to do with like the other thing that's really in the news right now is vaccine side effects. And everybody, the vaccine is like by far the most important conversation going on right now. And I've said this when it first rolled out, like what's going to happen is you're going to vaccinate tens of millions of people like in a very short period of time. And even if you have an adverse event rate that is exceedingly low, that's like really non-detectable by a research study, for example, because you're just not going to enroll that many patients, you're going to see some reactions. And what's going to happen is the news is going to write about the reactions to the vaccine. And we're starting to get a little bit of data on the numbers for those adverse effects. And they're very, very low. They're exceedingly low. They're on par with things like the other vaccines that we know about. As far as the two different vaccines, they both just in the last couple of days have published that they're more like kind of media releases than they are like actually scientific papers. But they're starting to publish their data with that's available in terms of these adverse events, and they're they're on par with any other vaccine, and they are almost exclusively like allergic type reactions. The anaphylaxis is like a severe allergic reaction. That's like the one that you're almost certainly going to see if you inject anything into enough people, like someone's going to have an anaphylactic reaction to it. And we have seen some of those. They're so rare. I think the numbers from the Pfizer, I can't remember if it was Pfizer or Moderna that published like a big data set, but they're like 1 in a million or something like that. I think there was 20 something anaphylactic reactions to like that have been reported, and they've given like 20 million vaccines or something like that. So whatever the case is this is an incredibly safe vaccine. If it wasn't, then we would already know that, having given 20 million vaccines already. So I think I am incredibly impressed with this vaccine and the development of this vaccine and the transparency with which it was developed and all the publications that have come out along the way. The phase 3 efficacy trials were very well done, very well conducted, with a lot of transparency, a lot of collaboration between scientists and industry. I am vaccinated. I am 15 days post second vaccination, and I can tell you, I feel like it's night and day. Like when I go into a COVID patient's room, I just feel so much more protected, and this virus is super effective so far as we can tell. And we're starting to see that efficacy in real time, like in places like Israel, who's vaccinated over a quarter of their population already. And I'm sort of digressing, but there's some interesting things coming out, because this is really exciting for nerds, because basically this is a real-time experiment with the vaccine. So now you have a ton of disease in the population, and then you're going to go out and mass vaccinate everybody, and then you're going to see what happens to the numbers of the disease itself, which is not, it's kind of rare. Like none of us have ever seen that in our lives. We, in the media, we hear people like arguing about whether or not vaccines work, for things like pertussis and for things like influenza and things like HPV and these things. But we have such a low prevalence of those diseases in our society. There's just so little of it overall that it's difficult to actually like visualize the efficacy of vaccines, because they've already done their job, over the last decades. But here we're going to actually see a vaccine probably eradicate or close to eradicate a disease, taking the disease prevalence from like virtually its peak. And probably my guess is that we're going to see a drop off, dramatically over the next couple of months. And so interesting, like if you look at Israel is just now, like in the last couple of days, like publishing their experience. They've vaccinated a quarter of their population, and many of those have been people over the age of 60. And they've already reported a massive decrease, like in their ICU admissions and hospitalizations. And it's only been a couple of weeks. Among UCSF healthcare workers, for example, I just heard this a couple of days ago. They just published or told us about our data. Like a month ago or a couple months ago, something like 15% of the overall COVID cases were healthcare workers. I can't remember the number, but it was pretty high. It was like in the teens percentage of the cases were actually healthcare workers, and already it's down to just a couple percent. Now, I don't know if I'm guessing that's the vaccine, but you can already see that because the only people that have been vaccinated right now are healthcare workers, and you can already see like healthcare worker rates of COVID infections like dropping off the cliff. My guess is that it's just going to be like one of the most dramatic things that any of us are going to witness in our time is watching this disease go from peak prevalence and just really, really everywhere to virtually like undetectable over the course of this vaccination campaign. That is, if we can get everybody vaccinated and people are up for it. There is a significant amount of hesitancy in our society. So yeah, the vaccines, Moderna, Pfizer, totally brilliant, very safe. I hear a lot of people get pretty achy and feel pretty crappy from the vaccine, both among peers and colleagues. Like some of them were like pretty wiped out. I would say a minority. Most of them, I would say, experience some sort of like immunogenicity or immunoreactivity, they call it, I guess, or they call it reactogenicity or some funny word like that. But you get achy and you get a headache and you get a fever. And some people were actually, I would say a small minority were pretty wiped out for a number of days. I didn't feel anything. I think like my first vaccine, I didn't feel anything at all. And then the second one I felt, I don't know, maybe like on day 2, I felt maybe a little bit malaise-y, like when you get the flu and your skin is sensitive, and that was my experience. But I have seen a lot of people like feel pretty miserable from it. But in terms of serious adverse events from the vaccine, having given 20 some million vaccines already in this country and not in across the world, that number is astronomically higher. You would see a signal if there was like a significant harm associated with that. But be aware that you will, in fact, see some reactions that are going to hit the news, and that's a function of the denominator. When you do 20 million vaccines in a month, you're going to see rare events. That's just a mathematical concept. So, Dad's on the call. Are you raising your hand there?
That's my hand, right.
All right.
I was just waving, saying hi. Hey, I got a question for you, though. When are you going to come visit me? No.
I'll tell you. I'll answer that.
Well, I'm going to come visit you before you're going to come visit me. It's on the plan.
Yeah.
But it's after the vaccine, by the way. Hey, and Melissa, by the way, has already had one. She works here at the local hospital.
Hi, Melissa.
And she's on the other computer right now. But I got a real question for you. And I've been reading about this. So I get a regular flu shot every fall. And I've been doing it for years. And haven't had the flu in a long time either. But as this virus, as you said, mutates, maybe becomes more contagious but less lethal, and becomes just part of something we deal with all the time for years and years to come, will that mean that folks, including me in my 70s, will be getting 2 flu shots a year or something like that? End of question.
Yeah, that's a great question. Another way of saying that would be, am I going to have to get a COVID booster every year? Coronaviruses. I'm going to do my classic, the way I answer. I'm going to digress for a minute and then I'll come back. And see, people have to be patient with me because I'm sort of verbose. Like I'll take a turn and I'll come back to your question.
Amen.
Yeah. Yeah. So the coronaviruses don't mutate like flu. Not a good comparison. Flu mutates like crazy. it's more of it's a little bit of a less of a stable genome. I'm not going to pretend to be a molecular biology, but you're not going to see the rate of mutation that you see with flu with the coronaviruses as a class, a function of class. But like I said, these RNA viruses can and do mutate, and it is very plausible an annual booster. How long? So the question can be translated into how long can I expect to have immunity conferred from a vaccine, or from an infection you also are going to generate a memory immune response to the disease. Nobody knows the answer to that question, Dad. There is some interesting and I would say reassuring information with respect to both the the molecular testing for somebody who has had a native infection or wild type infection. It seems that there is durable T cell and B cell memory immunity, like going over 6 months in the studies that, remember, this disease has only been around for a year. So it's like, how much data can you really have on something like that? But it seems like there's durable immunity to the SARS-CoV-2 after a native infection. And then in the other coronaviruses, which are ubiquitous, they're the ones that give you the cold every couple of years. I mean, we all get them like every couple of years. And we know that immunity is not that lasting for those. But it lasts like a year or two, but then you'll get
like rhinos.
Yeah, right. See, so they're all a little bit different, and rhinovirus is another example of a respiratory tract infectious virus to which you have immunity maybe on the order of, I think, a year or two, but you might get reinfected a couple of years later. Now, there's been some very fascinating recent research looking at old coronavirus strains that I guess, like the virologists like keep them in the freezer or something, and they look back at that were in strains of the coronavirus family that were from like the G of those infections like going forward in time, and they did show that there was some lasting immunity like over the course of years. But I think that everything that we know, and then the vaccine, there's literally like no data on how long you're going to be immune from the vaccine. That's really usable, but it does appear, at least when you test people's antibodies and like test their T cells and stuff, it does appear that it's durable, at least as far as we have put in. To your point, I think that it's maybe every 2 years, and for the reasons that you alluded to and the reasons that we're actually seeing in real, acquires a mutation that changes the binding, changes the spike protein to the degree that the antibodies won't recognize it, then yeah, you're going to need to get a booster. I don't think it'll be on the order of like flu, we really recommend that everybody gets the flu vaccine every year because it changes that much, But the difference is that all of us who have been alive for all these years are seeing and being exposed to different flu variants like every single year. So we actually have a little bit of a memory immune to various strains of that virus ourselves. So it's not totally comparable, and I don't know whether or not we're going to need an annual booster for this virus. I think there's a reasonable probability that we will, just based on what we know from other coronaviruses and some of the points that you made. So yeah, I mean, you might need to get two. You might have two. And then the other question is what's going to happen with COVID? Is it going to just stick around in our society forever? Is it going to become a quote unquote endemic virus, or is it going to disappear like SARS-1 disappeared? And you just don't know. I mean, viruses have different behaviors. It seems like this one's probably here to stay. That would be my guess, and I'm sure that we're going to have to do something as a community, maybe on an annual or every 2 years. I could certainly a booster come along. Don't know though. Don't know. It certainly seems that way at this point. It doesn't seem like it's going anywhere, and yeah, it will change to the point that you'll probably need a booster at some point. The beauty of these RNA vaccines is that it is really not a big deal to manipulate them slightly. Whereas like every single year with the flu vaccine, it's very hard to make. They have to like take all the data from the year before and all the genomic sequences from the most prominent strains from the year before. And it's actually like very difficult because by January or February of a given year, you kind of want to know what's going around because you're already starting to make the next year's vaccine. So it's actually like a complicated process. And I don't see that happening with this virus.
Thank you.
Yeah, sure. Angie, you're up next here. We have, what is the threshold to admit a patient with COVID versus treating in the ER and sending them home? That's such a good question. This is like the perennial question for all emergency department patients. Who goes home and who stays? This is pretty, I would say simply put, it's really just their respiratory status and oxygen. Do they need oxygen? Oxygenation and pneumonia and respiratory failure from a viral pneumonia typically leads to what's called hypoxemic respiratory failure, where you're unable to get enough oxygen. Like the surface area of the gas exchange that occurs in your lungs is just so beat up by the disease and inflammation that oxygen exchange actually becomes impaired, and so your oxygen levels will go down. I think that the oxygen level is really sort of the real hinge point for who we decide gets admitted to the hospital. As the disease progresses, if other it can result in things, low blood pressure or metabolic or laboratory perturbations like kidney dysfunction, and other organs can become involved. But really, when it comes to admit versus send home from the ER, it usually has to do with how well are they oxygenating and how well is their respiratory system working in their pulmonary system. So that's I would just leave it at that, really, with respect to admitting versus discharging the patient home. There are other things, certainly, not the least of which is like, where are we discharging this patient home to? Are they in a nursing facility where they're going to be at risk of transmitting the virus into a long-term care facility, which is disastrous, by the way? Are they homeless? Do they have a place that they can quarantine? Do they have a support system? Can somebody bring them food? It's very complicated discharging patients from the ED these days, the emergency room, figuring out all those like subtle disposition planning and making sure that there's a safe environment to go to has become a challenge like never before. But just objectively speaking, we're usually focusing on their oxygen level and their respiratory system. How Allison asks, is that anything you want to add there, Angie?
Just maybe what treatments are available in the hospital besides oxygen, or is it just oxygen that's available?
Yeah, that's the right now, like that's really what's happening, like on the medical front, in the medical and the clinical science front. There's just all
God, our
all these
internet is just
crap right now.
isn't it? God.
Is it completely frozen?
Pardon?
Is it completely frozen?
Yeah,
is
starting to come back.
incredibly important as far as therapy. The other therapy that we use a lot of, and you've probably heard of, is the antiviral medication that was made by Gilead called remdesivir. I could rant on and on and on about this, the clinical science behind these drugs. At great peril, you would be bored to death. Remdesivir is less impressive. Through FDA and all the protocols, it's being used around the world. It doesn't seem to have as consistent or measurable benefit as the steroids do. And that's not unexpected. Antivirals have a long history of being like marginally effective for a number of reasons. So we use a lot of, so most patients when they come into us, we'll give them steroids, we'll give them the remdesivir antiviral. And then in my environment, we're involved with a lot of clinical trials. So we're trying a lot of other medications. And then all the clinical trials that are coming out involve a ton of different medications that none of which have really had the consistent signal of mortality benefit or important benefits. And those fall into categories like the monoclonal antibodies, which are the ones that, DJT got, and the ones that are given to someone before they get sick, before they get admitted to the hospital. You want to give it really early, and it's basically an antibody, not unlike one of the ones that your body makes to the infection, and then it's supposed to like wipe out the virus before it takes hold. There's been 2 or 3, clinical trials, and the antibodies have been lackluster, to say the least. You're going to hear different opinions on this. I'm just telling you the data because I read all these studies, and research methodology and evidence-based medicine is a bit of a particular interest of mine. So the monoclonal antibodies, sort of not that impressive. And then there's this whole other sort of domain of therapies that I would call immunomodulating therapies, of which steroids does modulate your immune system. But a lot of people talk about this sort of immunological response to COVID, like in the later stages of the disease, that sort of follows the viral phase where your immune system goes sort of haywire, and people have been using the term like cytokine storm, and you've probably maybe heard some of that in the news. And so it stands to reason that you may want to wade in there with some drugs that might alter that immune function or that immune response, and see if that might benefit patients. So there's a number of drugs that block certain what are called cytokines and different immune chemical mediators in your body that are responsible for some of this disastrous sort of immune overload. And those trials are coming out, and there's a number of them. And for example, there was one that came out just the other day. It was published by this big clinical trial platform called RemapCap, which is a multinational clinical trial platform, not unlike the ones that the NIH runs. And they studied a drug called Tosilizumab, which is an interleukin 6. Interleukin 6 is one of these cytokines, and it's a blocker of that pathway. It's more of like a selective immune blocker, whereas steroid you can think of as like a non-selective. The steroids just like put the brakes on your whole immune system, whereas some of these other drugs are looking at targeting certain parts of the immune system that may be less side effects, maybe more targeted response. And this IL-6 hit inhibitor, Tosilizumab, seemed to improve mortality and reduced organ system support needs in severely ill COVID patients, like ICU patients. That just came out. That's an interesting study that may have some impacts on the way that we practice. But to shorten a very, very long and drawn out conversation about COVID therapeutics, we're just now like seeing like onslaught of clinical trials, and so far like there's nothing has really come out that's incredibly impressive. Hopefully that answers your question. But steroids definitely important. The remdesivir antiviral may be important. Any other questions about drugs or therapies? Okay.
Clay,
Allison, yeah.
let me pipe. Is there a faction in the medical community that's still promoting some of these hydroxychloroquine, all of these other things? Is there a rift in the medical community on that?
Yeah, I definitely would not call it a rift. I would say that this is a tough one, because it's hard, right? Because there is the idea of medicine and science is not, traditionally it's not a really it's not a clean-cut relationship, and a lot of medicine is art. A lot of doctors do crazy things. Let me put it to you this way. There's a lot of variation in clinical practice in medicine. Like one of you might go to the doctor with a respiratory infection, and they may say, hey, I'm going to put you on some azithromycin and actually give you a couple of days of prednisone, right? Then you may go to another doctor, and that doctor might be me, and I would be like, have some chicken soup and, these drugs don't work. And if you are prescribing something with no benefit, with no proven benefit, then you are only prescribing harm. And then there's this concept of like number needed to treat to benefit versus number needed to treat to harm. And you can only obtain those numbers by doing clinical trials. Hydroxychloroquine is a good example of how the field of medicine is not immune from cognitive biasing by any stretch of the imagination. In fact, it may be more susceptible to cognitive biasing than perhaps any area of our world. Hydroxychloroquine is a bit of a joke in a lot of respects because it never even really gained scientific traction, right? But it became like a talking point. And that goes to show like how the practice of medicine is not immune from your belief structures and your sociology and anthropology of like what's going on around you. And yes, there's a lot of disagreements among doctors. It comes down to this. There's a lot of uncertainty, right? There's so much uncertainty, and the human mind has to do something with uncertainty, and so they will either approach it from like a kind of a Bayesian perspective, like, yeah, this is not likely to work, and therefore I'm more worried about the harm than the benefit. Or they'll approach it from like we always tell our trainees, like, you have to learn how to just stand there and do nothing, because our mindset in medicine is I need to do something. I need to prescribe something. I need to do a procedure. I need to help this person. And so I think that leads to a lot of prescribing of things that are just like really don't pass the sniff test scientifically. So they say, medicine is an art and a science. And I believe that. I try to, in my practice in emergency medicine and ICU, I tend to try to stay on the sciencey side of things. And I wouldn't say there's a rift to your question. This is sort of the long-winded answer of saying there are small, you have undoubtedly heard doctors touting hydroxychloroquine on the news. That is insanity. That is true craziness, because there's no basis for that. But with respect to hydroxychloroquine, it's simple. That's a very small percentage of physicians who would support using hydroxychloroquine, particularly now that there's been randomized control trials, but they're still out there. But there are other more subtle things, like, do I put my patient on blood thinners? That's another example of wide variety in practice, because we don't have the data. There's a lot of blood clotting that is associated with severe COVID, and strokes and clotting of arteries and veins. So you get like a blood clot in your lung, that's a vein. You get a blood clot in your brain, that's an artery, that's a stroke. You get a blood clot in the arteries of your heart, that's a heart attack. You get blood clots in your kidney arteries, that's like kidney failure. It's a big deal. There's a lot of clotting. There's obviously like severe COVID, and the immune part of COVID like totally disrupts and jacks up your entire clotting system. And so there's a really, really good question is, should I just put these people on blood thinners? We wouldn't typically do that for another, like an influenza patient, who has, ARDS or pneumonia. But with COVID, there seems to be something going on with the clotting. And so many doctors and many hospitals across the country and the world have protocolized the use of blood thinners for sick COVID patients. And we've been waiting for these clinical trials, which actually have just put out press releases in the last week for both the moderate and the severe COVID patients, and with respect to their data on these blood thinner things. So that's another example of like these, variations in practice. When it comes to the really crazy stuff, like masks don't work and hydroxychloroquine is going to save the pandemic. And now it's ivermectin. You may have heard of ivermectin. It's an anti-parasite drug. There's some non-randomized, like sort of observational kind of Mikey likes it type studies that say it might help. And now a bunch of doctors are prescribing ivermectin. That's sort of the modern version of hydroxychloroquine, but there's no good science. So there are these little factions, and it's just how it goes. But I wouldn't say there's like a genuine rift in the medical community. The majority of people are mostly on the same page.
Thank you.
There's some subtle stuff, like what ventilatory mode, and like, do I do the blood thinners, and like, should I give 10 days of steroids instead of 5? Should I use 20 milligrams instead of 10? Like, there's some real good questions and really compelling stuff out there that makes decision making basically like impossible. You just have to sit down with the family and like talk it through. And also kind of you do what you do at your institution. Like in my institution, like we we are enrolling patients into clinical trials for blood thinners, and if they get randomized to the blood thinner arm, then we're going to put them on blood thinners. But if not, we're not just putting people on blood thinners for just because we think it's the right thing to do. Does that make sense?
Yes, it does.
It's a complicated time in clinical medicine when it comes to evidence-based medicine, science-based medicine, because there's definitely some unique features about COVID that make it a unique disease. This is not just the flu part 2. I mean, there are different pathophysiological, mechanisms involved that we don't understand, and so we don't know how to treat. We're getting much, much better, every day. But these questions come up, and it's just like, what do? You don't have the answer, and so you have to mitigate and you have to learn how to manage uncertainty, which is something our whole society could really benefit from.
Clay, go ahead.
Oh, I'm done.
Oh, okay. I'm just going to say we've used up your hour, but it's been wonderful. I really appreciate it. And if there are any wrap up, I think there was one question about the impact of the size of the infective dose that you get, whether there's a correlation to severity of the disease. Did you see that?
Oh yeah, let's see. What's your sense of the importance of dose as a major variable on disease severity? Are there direct and indirect data to support your sense? That's Shinoa. So hopefully I said that right. That's a great question. There's no real good data on this question. There's only indirect data, and I think it's compelling. And I'll just try to keep it brief. And I'm happy to stay on. If anybody wants to jump off, go ahead. I'm happy to stay here and answer some questions.
Katie Kurtz has got a question for you after you finish this one. So
yeah, I see her. Hi, Katie. So let's talk about this for 1 sec. The indirect data for this dose-related response is really interesting to look at the drivers of the pandemic, which are largely these so-called super spreader events, where you just see a whole bunch of cases come out of the same restaurant, or everybody in the choir practice gets infected, or everybody who goes to a certain family gathering gets infected from one index case. And so that tends to lead to a theory of somehow there's some interaction between the infected and the non-infected. It may be the person who's infected has a really high viral load, and so they're more likely to breathe out higher doses, as you say, of viral particles that you may be exposed to, versus somebody else who maybe is at a different phase in their disease and they're not as infective, or they don't have as many, maybe it's a dose response, or maybe it's just the immune response. We don't really know the answer to, but it certainly seems like there's some indirect data that argues for a dose-related response to infection. And I know there's some more elegant data out there that I've kind of seen a bit of, but that's not really my specialty, the immunology side of it and the infectious side of it. There's some interesting other observations in terms of, I think the spin from this, the most important thing to take home from this question, what is my risk of getting infected in X, Y, or Z scenario, is to absolutely stop tiptoeing around the question of whether this virus is transmitted via an airborne route. And I know that I don't know if this has hit home for any of you guys, but it certainly has been a very poorly messaged thing with respect to the CDC, and all the way up the chain throughout this, we've been saying, oh, we don't know if it's transmitted via the air, or whether it's larger droplets, or whether you can get it from touching a surface. It's all three. And there are certainly going to be circumstances in which the virus is airborne, and you can get it from being in close contact with somebody who's breathing it out. You don't have to be in their face. They don't have to cough in your face. This is the importance of masking. This is not a question anymore, and I think that people still tiptoe around it. So, it might be more of you're in. It may be the ventilation in the room, more so than the dose of the virus that you're exposed to. It just really depends on a number of factors. I personally believe that there is a dose response. You just have to assume that if somebody's in the active viral replicative phase, and they cough in your face. I mean, as an emergency doc, like this happens to me every couple of years where, I'm looking in some kid's throat or something and they just cough right in my face. And I'm like, oh, great. There's my cold for the winter. Like I know exactly where I got it. So, but I don't have anything more elegant to say that's more compelling. Hopefully that answers it to the best of my ability. We could talk about that one for a while too. It's pretty interesting. What do you think? You got a question there, my friend? Good to see you.
Hi, good to see you. Yeah, circling back to vaccines and reactions. So I had my first dose and I didn't have a bad reaction, but it was long, like at the injection site. It was 9 days later, I still had a lump. It was red, it was hot, it was sore. And I hear that the second dose, you can have a greater reaction. So would that be kind of more of that same reaction or different?
Again, it's just like such a tough question because you just don't have the science to answer. Like you can't really base you have to, I guess, to answer a question like this, and like so many questions, you just have to make assumptions based on like, what's most likely, what's most physiologic, what's plausible. With respect to like a localized soreness like that and a lump and like a localized reaction, that is something that you might, there are some people that got more sore, their arm got more sore the second time around, and there are people who didn't get sore at all the second time around. For every person, so there's both versions of the story. When you do get like a localized like redness, swelling lump, the question is like, did the needle that they stuck into you, did it like hit a muscle? Did it hit the muscle and like cause some like local tissue damage or inflammation, or was it actually like an immune mediated response? When you get like the red skin and it's hot and it's lasts for several days, it's probably immune mediated. So
it's also like the itchiness came 9 days later. All of a sudden, I couldn't stop itching it for 3 days.
Right on the skin. Right on the skin. Right
on the skin. Yeah.
Yeah, and that's probably just from a localized immune response with like blood vessels dilating, releasing histamine, that kind of stuff. I would say that it's probably equally likely that you're going to have like a worse kind of sore arm as it is.
Arms a lot is why I'm like, how many days can I do? Yeah. I have to work.
Yeah. I honestly think it's equally likely that you won't have any reaction at all.
Okay.
It's difficult to say. With respect to like more global, like if you were saying to me like I got super achy and I had a fever and it lasted 3 days, like, is that going to be worse? It seems to be in this was borne out in the phase 3 trials too, that the second dose seems to be a little bit more reactogenic, is that the word, than the first. So I think that the running theory on this is that your whatever reaction you have on the first go is probably going to be a little bit worse on the second go.
Okay.
But I don't know if I don't necessarily believe that that's true. That's just what we tell people right now, because that's what observationally that seems to be the case.
Is that your body kind of recognizing that it's being attacked and it needs to? Okay.
Yeah, the crappier you feel, the better it is. I'm like all worried because like I never react to any vaccine. I get my flu vaccines, I get updates. I never react to anything. But then again, like I also don't like get itchy when I roll around in the grass in the summer, or mow a lawn, or when I breathe in pollen. I don't have allergies. I don't have food allergies. I don't get. Some people have like skin stuff where they'll get too much sunlight and they'll break out in hives. I mean, people's immune systems are kind of set up for this. There's wide variability like in people's underlying immune system. And it must participate in how people react to vaccines.
Awesome. So, well, thank you. I have to actually, my lunch break's over, but I appreciate you doing this, Clay.
Yeah, it's so good to see you. Thank you for coming.
Take care.
Okay, so we got that, and then I guess there's one last one here. Hopefully we won't need, this is from Angie. Hopefully we won't need, oh, that was in response to my, okay. Oh, geez. All right. Yeah, okay, so anybody else want to say anything or any other questions? I think we got through our questions. From the chat.
I want to say good luck on the rest of your residency. Can't wait till you get a chance to get back here.
Oh, I dream about it every day.
And yeah, and just thanks for the, every once in a while, if we're still fighting this thing 3 or 4 months from now, I'll call you up again.
Yeah, I know. Well,
by the way,
go ahead. You go ahead first. Sorry.
Well, I was going to say our numbers in Oregon all of a sudden started to dip pretty dramatically. Our hospitalizations in the state went down from 400 to 300.
Yep.
And Wallowa County has been blessedly immune from the whole damn thing. I mean, I think we've had 90 cases total, 3 deaths. And we're down to, we now are getting 1 or 2 cases, maybe 4 or 5 in a week. And almost always they're traced directly to a visit outside the county. So there's no community spread here.
Yeah.
And the interesting thing about that is that it's also, we don't have 100% compliance on masks, and we're still eating inside restaurants to a certain extent. They're distancing you. So are we just healthier, or maybe we still do get to breathe a lot of outside air?
There's so many factors. You know what the biggest factor probably is just straight up luck, straight up chance. I mean, it's all statistical chance.
Yeah.
And that's the world of biology, and like so many different places in the United States have learned that the hard way. Once the virus gets a hold in the community and starts circulating and reaches this, that's the whole concept of this like reproduction coefficient that people talk about, like the R naught and like the transmission coefficient and all these things that the epidemiologists like to nerd out on. Once the virus like reaches a certain threshold within your community, it just takes off like wildfire and is literally everywhere. And like you've heard of these places like where positivity, test positivity rates like exceed 50% and stuff. I think about San Francisco in the same way. Is it because we're doing a good job as a society, like in terms of like following the rules and being careful and whatnot, or is it just totally blind luck? That's the thing about probabilities is you just don't know. But I'm really happy to hear that. I worry, about Wallowa County and some of the other small rural areas that I've spent my life in, because having that occurrence in one of these rural towns, like has happened in so many other places in the States, and like South Dakota and like all these places where these rural towns just get completely swept out by the virus. Like it's just disastrous for the community. So that's great to hear.
In fact, rural Oregon, Clay, I think what's interesting is almost Umatilla County, very hard hit. Umatilla County has what? Food processing.
Exactly.
Workers in the field who crowd into a crummy and drive home to crowded housing. Umatilla County, we had an outbreak at a church, one church that probably, that insisted on going forward. So almost all the cases we have here in Oregon, where Governor Brown did shut things down early and has gradually loosened them up, we seem to fit all the protocols, we seem to, like your San Francisco maybe, huh?
Yeah, it's you do the best you can. There's no question that these non-pharmacological interventions work, to some extent. I mean, they work, distancing and masking and things like this.
Yeah.
But at some level, there's just some mathematics involved, some probabilities and bad luck. With that, I want to end by saying, I just wanted to back up and address a point you made. I am feeling so hopeful about this problem now for the first time. The vaccine, I don't think that the vaccine messaging that's going on in the media right now is the right way to go about this. I keep hearing people say things like nothing's going to change. You can't go see your family even though you're both vaccinated. I mean, that's absurd stuff. This vaccine is going to, it's going to take a while. I want to be clear. We need to vaccinate everybody over 60. We We need to vaccinate everybody who's, has any comorbidities, vaccinate the teachers, get the kids back in school. But as soon as you vaccinate like the older people, like they've done in Israel, like all the ICU admissions and hospital admissions disappear. And, effectively the pandemic ends, because that's like the pandemic is the resource strain. So I just hope that everybody is like very excited about the next few months, because once we get this vaccine out in earnest, like this pandemic is going to go away. So, finally, so be happy. Like, don't, I mean, it's pretty dire right now, and we certainly have to keep doing what we're doing now for probably quite some time. But there's a big bright light, at the end of this moderately long tunnel.
Clay, I just want to say thank you again for everybody here. And we wish you the best, and we'll talk to you again soon. Thank you, everybody, for showing up. Next week, the Nature Conservancy and deer and elk tags. If you can fit that in, Clay, in your schedule, you can take a break and watch us talk about deer and elk tags.
Oh, I'd love to. Well, thank you so much for having me, everybody. Take care of yourself.
Thanks, Playboy.
Bye-bye. There's his one.
Yeah, I saw her. I talked to her when she first